BMJ Best Practice Comorbidities Manager in Action. Um, Ryan, I wonder, can you please confirm that the slides are visible?
Yes. Yes, we can see
Wonderful.
them.
Thank you. So thank you very much for the kind invite. I'm Kieran Walsh. I'm Clinical Director at BMJ. I am a general internal medicine physician, plus editor, plus educator, and I have a role here ensuring the quality and safety and implementation of BMJ best practice, our clinical decision support resource. And this is the second in a series of webinars that we're delivering related to BMJ best practice and BMJ best practice comorbidities manager and evidence-based medicine more generally. And in this webinar, I'm going to talk briefly about BMJ best practice in action, about how the BMJ best practice comorbidities manager works. I'm going to talk about further resources on BMJ best practice, which you would not have heard about so far, everything from the podcast through to CME CPD. And lastly, I'm going to end with a little bit about the use of BMJ best practice in quality improvement projects and also in medical education projects as well. So BMJ Best Practice is our clinical decision support resource, continually updated, evidence-based, actionable, and practical content aimed at doctors and other healthcare professionals. It's essentially a knowledge resource which helps to give doctors and other healthcare professionals answers to their clinical questions. They don't just get any answer, though, they get an answer that's focused on their needs. And those needs are that they can get knowledge quickly within seconds, that they can get practical information that's evidence-based, updated, and also accessible. And as well as the challenge of keeping up with the evidence-based and learning how to manage patients with single conditions in an evidence-based way, there's also a challenge of managing patients with more than one condition, so-called comorbidities. This is important for a number of reasons. Most patients in the acute setting, but also in the chronic setting, have more than one medical condition, and yet clinical resources traditionally focus only on patients with single conditions. And when comorbidities are not taken into account, patients get suboptimal care, which can lead to worse clinical outcomes. Comorbidities are also associated with longer lengths of stay in hospital and also increased morbidity and mortality. In light of all these problems, about 3 years ago, we launched an add-on to BMJ Best Practice, which we called the BMJ Best Practice Comorbidities Manager. And the Comorbidities Manager prompts users, doctors, or clinicians to consider a patient's comorbidities when finding information about treatment of an acute condition. So the idea is that you look up the patient's acute main condition, then you add the patient's comorbidities, and you get a tailored management plan, a management plan that is tailored or personalized to the patient's unique circumstances. And this resource helps to support healthcare professionals in treating the whole patient and thus delivering holistic care. Treating patients like they have just a series of single conditions doesn't work. and yet an awful lot of medical education and knowledge resources and research is focused around patients with single conditions. And so what we're trying to do with the BMJ Best Practice Comorbidities Manager is start to rebalance things and to start to solve these problems. And how it works is you have a patient with an acute condition, maybe COPD, and you can add one or more of these chronic comorbidities to the patient's treatment algorithm. As you can see, the comorbidities mentioned here are all common, important, high-cost chronic conditions, from diabetes through to hypertension. They're common around the world, and we know that they're common in Mexico as well. They also, importantly, include mental health conditions like depression and dementia, because mental health comorbidities are very commonly neglected. And also they include things like frailty, which is not a disease, but is a patient state and which can affect patient outcomes and is important, particularly in older patients, but it can occur in any age group. And to date, the BMJ Best Practice Comorbidities Manager is the only resource, the only clinical decision support tool that's designed to address the issue of managing patients with comorbidities. And this is a clinical tool. So I've put together a clinical scenario to bring it to life and to explain how it might work from a clinical or educational perspective for doctors and other healthcare professionals. So we're going to start off with a very brief clinical scenario. Say an 82-year-old man has cough and shortness of breath, and he's bringing up green purulent sputum. This 82-year-old man has a history of COPD and also type 2 diabetes, which is controlled on diet and metformin. On examination, he has wheezes and crackles, and he also takes inhalers for his chest condition. So this is not a diagnostic challenge. It's very straightforward to know what the diagnosis is. It's COPD and type 2 diabetes. However, it is a therapeutic challenge, a management challenge, as we're going to see. And so imagine for a second that the scenario splits in two. And in the scenario on the left, we just think about the acute condition, COPD. The patient will then receive bronchodilator, steroids, and antibiotics, but without monitoring or management of the patient's diabetes. And in the scenario on the right, the patient will still receive bronchodilator, steroids, and antibiotics. But in this case, because the BMJ Best Practice Comorbidities Manager advises it, it will be with careful monitoring of the blood sugars, a review of the diabetes medication initially and throughout the hospital stay, adjustment of the diabetes medication, and a check for pressure ulcers as well to avoid those. And so what happens? Well, in the scenario on the left, if you don't manage the diabetes when somebody's taking steroids and don't do regular blood glucose checks, the patient will develop hyperglycemia and also renal impairment. There'll be no review of the diabetes medication, metformin will be continued, and the patient will likely develop renal failure. So multiple things go wrong. But if you use the BMJ best practice comorbidities manager and manage the COPD and the diabetes together, then you'll continue to control the blood sugar throughout the hospital stay. You'll review the diabetes medication, and the patient will improve quickly from a COPD perspective, but also from a diabetes perspective. So to deliver high quality care for the very many patients with comorbidities, we need to use resources that are designed to help with this particular problem, i.e., delivery of holistic care and the simultaneous management of multiple conditions. And I said that comorbidities are common around the world, and so they are. And so it's unsurprising that they're common in Mexico as well. There are multiple studies that demonstrated this. This is just a small sample of papers used for illustrative purposes. So one example at the top, Bustos Vasquez looked at patients in Mexico hospitalized with COVID-19, a high prevalence of comorbidities. What comorbidities did they find? Diabetes, hypertension, obesity. Garin, in the second paper, looked at multimorbidity in patients older than 50 years, a prevalence of 63%. The morbidities found: hypertension, diabetes, obesity, depression. And last, Smith et al. Looked at multimorbidity in people at age 50 as well in Mexico. Prevalence of multimorbidity of 43%. The morbidities they found, once again, hypertension and diabetes, but also arthritis and chronic lung disease. So this is a universal problem. And if we're going to improve healthcare within countries, we need to start to solve this problem. And using the tool is part of the solution, but there needs to be a wider, improved management of patients with multiple diseases, which involves taking a person-centered approach, finding out what matters most to the patient, which disease is most important to them, and prioritizing that. Looking at how conditions interact with each other, like diabetes and COPD, looking where possible at streamlining medications and sometimes deprescribing, making sure that care plans are simple so that patients and their families will be able to follow them, coordinating care. Patients with multiple conditions often see multiple healthcare professionals, and we need to coordinate care between those different healthcare professionals, doctors, nurses, pharmacists, etc., to deliver improved care for patients. But we need to do more. Some of the most commonly neglected comorbidities are depression and dementia, anxiety, and we cover those in BMJ best practice, and we cover depression and dementia in the comorbidities manager. We need to empower patients so they can self-manage their own conditions, and I'll talk more about that in a second. We need to think about the future and sometimes plan for changes or transitions. We need to be realistic and know when sometimes we cannot blindly follow guidelines. And we need to keep everything under review because disease severity may change over time. A patient with 2 comorbidities may develop a third, etc. Now, I said I would mention a number of other resources on BMJ best practice, which can help with the implementation of evidence-based medicine. And one of these is our podcast series, where we interview leading international experts who are authors or peer reviewers for BMJ best practice. They're clinicians plus academics, and we interview them on their disease that they have written about how to diagnose, how to manage, and most importantly, how to get evidence into actual clinical practice. That's part of the the area that we most focus on. And the podcasts are freely available. We'd encourage you to listen to them as well. There's multiple advantages of learning and delivering medical education through audio, through podcast. It's flexible, it's mobile, your hands are free and your eyes are free as well. It can support something in medical education called spaced repetition, where you can replay the content for reinforcement. You obviously get a break from screens, and sometimes audio can help certain groups of learners to concentrate better. There's more advantages. The best podcasts include pauses, storytelling, reflection, which encourage deep learning and better absorption of the medical information. Obviously, it can help people who have problems reading or who have visual problems. And also, they can be conversational and engaging, and people actively like them. So do listen to the podcasts. I should say that accessibility of the evidence is almost as important as the evidence base itself. If you can't access the evidence, you won't be able to learn about it and use it. And so BMJ best practice is mobile optimized, regardless of the type of mobile phone you might have. There is also an app which is quick and easy to download and uses minimal storage in your phone and is available offline. And you can download it on your own personal phone as well. We also have patient information leaflets on BMJ best practice, and these are vital to our empowering patients with single conditions or multiple conditions. It doesn't matter. And the patient information leaflets that we have, they follow best practice in the generation of patient information. And I'll summarize what this is very briefly and quickly. And I should say, just as an aside, I'm very happy to share the slides with anybody who wishes them to have them at the end, and my email address will be on the last page. But in our patient information resources, we use plain language. We focus once again on what matters to the patients, mainly the symptoms that they suffer from. We keep them short, maybe 2 pages long, and we keep them evidence-based and continually updated, just like the professional content, just in simple layperson's language, aimed at a reading age of 12. We try and make it actionable to give practical advice to patients. Of course, we use respectful and indeed patient empowering language. We use visuals where possible, and we encourage patients to ask questions of their healthcare professionals so that they can feel empowered to do that. So sometimes that they know what to ask. One other important point about access is that BMJ best practice can be made available through the electronic healthcare record. The content is chunked up and semi-structured. It's tagged and coded to ICD-10, SNOMED CT, It's HL7 info button compatible, and we're working towards the FAR standard. And so what all that means is that BMJ best practice can be integrated into the electronic healthcare record or other clinical systems as need be, with a simple linking or with a search widget or full API HL7 info button integration. And we're keen that BMJ best practice is used not just as a knowledge resource or not just as an electronic resource that will generate clicks or likes or hits, but it actually be used to deliver improved care for patients and improved education for healthcare professionals. So we're keen to see it used in clinical quality improvement. And quality improvement is simply the process of analyzing, assessing, and enhancing quality of healthcare. It should be a systematic process, and it can look at improving practices or processes or ultimately outcomes for patients. And typically, quality improvement means all these things from 1 to 6: measurement and assessment, analysis, setting goals, monitoring feedback, etc., etc. It should be an iterative process. And we're delighted, and one of the downsides of quality improvement is that there's a lot to do. You need to describe the problem, look for relevant available knowledge, develop a rationale, intervene, and measure. So a lot of work in quality improvement, but the good news is that BMJ best practice can help with lots of these different things. And we're delighted to see a growing number of doctors and other healthcare professionals and teams use BMJ best practice in quality improvement projects and writing up quality improvement reports. Once again, multiple examples of this. Here's one from England where they implemented a rib fracture pathway in their hospital to improve patient care. They based it all on BMJ best practice. Another smaller project where this group of doctors and nurses use BMJ best practice and patient information resources to deliver a quality improvement project. Another one from London where this hospital trust, the lab staff, improved turnaround times for this important test, and they use BMJ best practice to verify their standard of care. Another one here where they redesigned drug charts to prevent iatrogenic paracetamol toxicity. They use BMJ best practice to build the evidence base for their intervention. Another one here, this from China. So these are from around the world where they integrated BMJ best practice into the electronic healthcare record, and they improved the accuracy and the speed to diagnosis. Another one here from physiotherapists, so not just doctors, where they did a QI project to reduce the duration of tracheostomy in situ and hospital stay. They use BMJ best practice to define the type of brain injury in this group of patients who had acquired brain injury. And they improved care and they saved costs as well. Another one, an international one from Georgia, where they drove an educational initiative to improve the quality of care. And lastly, and this one I think we're quite proud of, because here we show the usefulness of this resource in the most challenging group of patients with multiple chronic conditions. And we got a good outcome from that as well, insofar as it was shown to be useful. Last couple of slides. BMJ best practice provides international guidance and evidence-based, and it's based on best-of-breed international guidelines, but also systematic reviews and meta-analysis, randomized controlled trials, and also the Cochrane reviews. But we know also that institutions and countries have their own local guidelines, their own organizational guidelines, maybe related to local care pathways or local protocols or checklists. And so we enable institutions to create links to their own guidelines as well as the international BMJ best practice guidelines. And this can improve clinical workflow and also improve adherence to local and global standards at the same time. So people really, really like this. And so we can put local information on the summary page of a particular topic or on the guideline section of a particular topic, exactly where and when they might need it. So one practical example is antibiotics, whereby antibiotic resistance patterns are obviously different in different parts of the world. And so we can give the international principles on choosing the antibiotics, but you can say, well, what antibiotics for a UTI should be chosen locally. BMJ best practice can also be used in education to do all these things, support curricula, track learning. It's accredited for CME, CPD, and vitally, it can support self-directed learning. And self-directed learning is really important. It gives control to the learner. So the user can use BMJ best practice as an educational tool as well as a clinical quality improvement tool. And the learner is in control and can fit their use of BMJ best practice around their schedule. They can do it at a pace that suits them, and they can explore topics that suit them as well. It supports lifelong learning, and by its very nature, the learner is motivated to look things up that they need to learn about. And they will develop problem-solving skills too. As well as all this, it's quite fast and efficient. You have a learning need, you look it up in BMJ best practice, you put it into practice. So it has impact as well. And the whole process can take just a few minutes. And yet that may be the most important learning that a doctor or other healthcare professional does on that particular day. BMJ best practice can be integrated into curricula. I'm just going to run through the next few slides because I know we have to stop soon and I want to leave time for questions in case there are any. When you register, and we encourage everybody to register, the system will track and record your activity on BMJ best practice, and you can generate a certificate of your activity and thus demonstrate all the learning that you've done and reflect on that learning and capture the reflections and capture the impact as well. So this is good medical education practice. You can get CME credits from it too. And we've demonstrated, once again, in another trial, the effectiveness of this approach, the effectiveness of using point-of-care information systems in self-directed learning. I always try to include the principles of BMJ when I can. These are group-wide principles. They are important. I won't read them all out. Ones that are particularly relevant are the fact that the content is independent. There's no advertising, no sponsorship. We're transparent about competing interests we may have, or authors or peer reviewers may have. Of course, it's evidence-based, and by providing patient information, we also feel that it's patient-centered as well. So I'm going to leave the demo. We might have time to do a demo at the very end, but I'm just going to pause for a second now, just in case people want to take my email address. I'll leave this up there on the screen for a second in case anybody wants that. And I'll stop sharing my screen now. So I'm happy to answer any questions that people might have, and possibly best to put the questions in the chat if there are any questions.
No question at this time, Dr. Kiran, but thank you very much. Your presence and your participation in this session with this information is very important to us. So thank you so much for being here.